Welcome back. It's time for our final panel, and one that we are particularly excited about. The National Cancer Institute and Fight CRC are tackling early age onset colorectal cancer. We are thrilled to welcome Dr. Matt Young, Program Officer, Division of Cancer Biology, National Cancer Institute, and Phil Dashner, Program Director, Division of Cancer Biology, National Cancer Institute. Dr. Young is a program director for gastrointestinal cancers at the Cancer Biomarkers Research Group, Division of Cancer Prevention, and Dr. Young is well recognized for his earlier studies in the Laboratory of Cancer Prevention at the NCI, where his research was focused on gene regulation of tumor production, mouse models for cancer prevention, and dietary intervention to prevent colorectal cancer. Phil J. Dashner, MSc, Program Director, Division of Cancer Biology, currently manages a portfolio of basic research grants focused on the mechanisms of biologic carcinogens for the cancer immunology, hematology, and etiology branch of the NCI. He received his graduate training from Arizona State University and has a background in microbial genetics and drug discovery from natural products, which includes the initial purification and testing of virostatin and the identification of curcumin and resveratrol as natural ligands in the aryl hydrocarbon receptor. And moderating the discussion is Fight CRC's own Andi Dwyer. Andi Dwyer is our research and patient education advisor. She also works at the University of Colorado Cancer Center. Andi is a public health practitioner with the University of Colorado Cancer Center and Colorado School of Public Health. She joined Fight Colorectal Cancer to advise the development of research and health education programs based on her experience in cancer prevention and control research. As the director of the Colorado Cancer Screening Program, she is a leader in patient navigation and established one of the largest screening patient navigation programs in the country. Andi currently serves as the chair for the National Navigation Roundtable and incoming chair to the Colorado Cancer Coalition. Colorectal cancer is personal to Andi. Her mother was diagnosed with an early stage disease in her 40s, which has sparked Andi's passion for early age onset research, leadership to convene international research collaborations, and alongside Fight CRC and the American Cancer Society, she actively engaged in the new data review processes to update the ACS's guidelines from 50 to 45 in 2018. And with that, we'll turn it over to Andi, followed by the rest of our panelists.
Hi, everybody. Good afternoon. It's great to see everyone, and super excited to have Dr. Matt Young and Phil Dashner, who have been my partners in crime, so to speak, over the last year to really engage in early age onset discussions for research. And I just want to take a moment to say that we really have enjoyed so much of the work that the National Cancer Institute and many of the partners who joined from our federal agencies this morning, including the American Cancer Society, the Department of Defense, NIH, FDA, and many others have spent their time and energies in really looking at early age onset disease. So I'm really excited to have the opportunity to moderate this panel. And from the team at Fight CRC and Mission Control, will we have an opportunity to go ahead and throw my slides into the queue? Okay, great. So I'd like to get started this afternoon by talking a little bit about the active collaboration that we've had with the National Colorectal Roundtable. And I think, as Molly has noted throughout our discussion, is really the name of the game is partnership. So the NCCRT, the American Cancer Society, Dr. Tom Weber and his team, many organizations throughout the country have been, for the last 5 to 10 years, really engaged in understanding what is no longer to be anecdote related to the uptake in young folks developing colorectal cancer. And in 2017, had a great opportunity for Fight CRC to really engage this work with the leadership of many of the partner organizations who've been represented today, and also the research community, as well as the patient voice. ultimately, we were able in February of last year, just about a year ago, to convene one of the larger discussions around etiology and study of research aims to really think about this incidence uptake in colorectal cancer. And I think when we look back to 2015-16, when we were starting to see data that, of course, it was no longer anecdote, but that it was a really legitimate scientific and medical concern, that we were seeing so many young folks dying and developing the disease, that we really needed to do more about this work. So in partnership with so many of the folks, we really did have taken a time to develop an early age onset working group. We've convened national leaders as well as international leaders in our first discussions in February with over 5 countries, and we're gearing up for some great work in 2020. And hopefully that if we can this summer make a travel to Europe to have some discussions with over 18 countries about furthering our engagement in the international work around colorectal cancer. So Dr. Dasher is going to talk a little bit about some of the group and the work that we've done together and some of the things that we're exploring in terms of etiology, causation, and understanding the reasons for colorectal cancer. So we're really excited to have Dr. Young go ahead and take us from here. But before, as we cue this up, I just want to say a huge thank you for everyone who's been engaged in this work. And I think that we have a number of families, advocates, and folks who've lost people or are going through the fight right now. And this is a very emotional time for Fight CRC. And I think that emotion and that passion is really what's driving that work from our advocacy and patient community. So Matt, or actually Phil or Matt, who would like to go first, given where we are with our technical situation? What works best?
Andy, this is Phil. I think I'm gonna present the first set of slides, and then Matt's gonna take over from there.
Fantastic. I'm glad we're going with the plan. So thank you, Phil. Please move ahead.
Okay, thank you very much. I am flying blind here, but I have my set of slides, so hopefully if I could just get confirmed that slide 1 is showing a nice graphic of the human GI tract, and it has Matt and my information on the left-hand side. Are we good with that?
You got it.
We sure are.
So I want to thank the Fight CRC meeting organizers for inviting us to speak to you all today. I realize this audience has a broad interest in all aspects of colon cancer research and treatment, but as Andy mentioned today, we're going to focus our talks today on early onset colon cancer and tell you about some of the plans that NCI has developed to help support research to combat this disease. Next slide 2, please. So, we have to start with a disclaimer. So first, while Dr. Young and I have no potential financial conflicts to report, I do need to say that our information presented today does not constitute official NCI policy. Next slide, please, 3. So, our talks are going to be divided up into 2 halves. First, I will cover some of the information we have on early onset colon cancer and what it is, and some ideas for what we think may be causing the increase in its incidence. And then in his talk, Matt will cover information on the detection and screening of early onset colorectal cancer and some of the plans we have for moving the research forward. And I do want to say also that as I'm speaking, if anyone has any questions, I'm not sure how this is going to work with the technical problems we're having, but please jump in and ask any questions, and we'll stop and field those as we go. Okay, I should also start by saying that we recognize early onset colon cancer is a big problem and that it can really strike anybody, including Andy's direct family experience with the disease. Just in the news today in the Washington, D.C. area, one of the Baltimore Orioles star players, Trey Mancini, who's 27 years old, it was reported is now being treated for colon cancer. So really, it's a disease we should all be paying attention to. Next slide 4, please. So one of the big questions facing scientists who research colon cancer is this fact that cases of early onset disease in the U.S. and Western Europe are increasing. I should mention that we're defining early onset colon cancer as sporadic cases that are diagnosed before the age of 50. So these are not cases that are associated with what we call germline mutations or familial syndromes like Lynch syndrome. There, the genetic causality of the cancer is well known. So these are not sporadic disease, and those genetic causes are not rising in incidence. So the increasing cases of early onset disease are represented in this figure from a 2017 report in the Journal of the National Cancer Institute that came from Rebecca Siegel and her colleagues at the American Cancer Society. If you look at the right-hand side graph, the scientists, what they did in the paper was analyze several decades worth of data on colon cancer, and they found this alarming rise in cases of early onset disease. These cases of sporadic disease have risen by more than 50% since 1994, as hopefully you can all see on the arrow there. They found these increases are occurring both in men and in women, and it's occurring at a time when actually the overall rates for colon cancer have been falling for some time, and that is seen clearly on the graph on the left. Next slide, number 5, please. So when these increases are viewed from a birth cohort perspective, the data show that the increased risk of early onset colon cancer is actually accelerating or seems to be accelerating, and that's measured by a year-over-year increase in the annual percent change as cases at younger ages, and that's seen in figure graph A of the figure, where you can see in the 20s and 30s the annual percent change is about 2 to 4%. When you get to about age 50, the increase is actually become a decrease, and you're actually decreasing in risk. The study also compared in the right-hand side of the graph, figure B, so compared to people born around 1950, which is the low spot on the graph, those born in 1990 or now have about double the risk of early onset colon cancer and quadruple the risk of rectal cancer. Since the genetics of early onset disease don't appear to be distinct from normal onset, that is, there's not a different set of mutations in the cancers, the birth cohort effects suggest that changes in early life exposures to known or unknown risk factors for colon cancer may be what's driving the increase in risk of early onset disease. And that's just graphically, the text in the box on the right tells us that. So following the 2017 report from Siegel and colleagues, next slide please, number 6. Following that report, the NCI helped to organize or participate in a number of meetings discussing early onset colon cancer. Two of the key meetings include the December 2017 National Colorectal Cancer Roundtable meeting that was held in Bethesda, Maryland, and then the February 2019 Fight CRC workshop that was held in Denver, Colorado. These meetings brought together a group of national experts on colon cancer, and that provided us with some very important feedback and a great overview of the state of the science related to early onset colon cancer. The information also helped us to define what are the knowledge and resource gaps in the field that need to be bridged before we can move the research forward. And the roundtable and Fight CRC meeting also made some specific recommendations for developing a strategic plan of action that we hope will accelerate research discoveries for new treatments of the disease. Next slide, 7, please. So one important step in developing that plan of action was getting the information out to the scientific community, and that was done by publishing the workshop report in the journal Gastroenterology last year. A couple of the key recommendations from the report were, and now looking under recommendations, the first red arrow, The first recommendation highlighted was to support additional research on early onset colon cancer through focused funding opportunities. And my colleague Matt Young will tell you more about those plans in his presentation. Then the second highlighted recommendation was that we should be considering new risk factors for what might be causing the increase in early onset cases. So a lot of time was spent at both of these meetings discussing the types of risk factors, and I'd like to show you what kind of risk factors we're talking about. So next slide 8, please. Several studies have looked at different environmental or behavioral risk factors that are known to affect colon cancer risk overall. So looking at the top box on this graphic, changes in exposures to things, to different factors were measured in data from 2 large national population health surveys. And these surveys found that risk factor exposure by birth cohort, again, or by age, to things like genetic susceptibilities, physical inactivity, or alcohol consumption, those risks have not changed much since going all the way back to the 1960s. The middle box, so things like smoking and aspirin use, have actually been decreasing among the young since about the 1970s. However, there were several known risk factors for colon cancer that show a coincident rise along with the cases of early onset disease. So these risk factors have kind of moved up to the top of our list of exposures that might be contributing to the increase in early onset cases. And those risk factors include those in the box down at the bottom, things like increases in obesity rates in the U.S., TD2 is type 2 diabetes, and prediabetes metabolic disease have been increasing along with cases of early onset colon cancer, as has antibiotic use, especially early in childhood, and then changes in our diet, such as a level of meat consumption and food additives. Next slide, please. Number 9. It was striking to those of us at the meeting, at least, that these coincidentally rising risk factors are all known to directly impact lifetime changes in the gastrointestinal microbiome. So microbiome has been in the news quite a bit the last few years, and we think this connection between the populations and types of bacteria and other microbes too that live in all of our GI tracts, that these connections to or associations to early onset colorectal cancer might be very fertile ground for investigators to explore. Next slide 10, please. So as we went through the meeting, we developed some ideas, and this graphic just shows an overview of how those major coincident risk factors might be interacting with each other and with host factors, which is a term we describe as, if you look all the way to the left on that graphic in the fuchsia colored box, we describe these as gene-environment interactions. So we know that things like diet, obesity, bacteria, and antibiotic, the yellow boxes on the figure, can all affect how our genes are regulated. But we don't know if and how those are contributing to risk of early onset colon cancer. In our discussions, we tried to capture some of the contextual elements of these interactions, that is including temporal effects of exposure, which are the green boxes. So what we're interested there is, does it make any difference if you're exposed to a given risk factor early in life, early in childhood, or in adolescence, or later in life? We also wanted to look at any disparities in the demographics of exposure. So that's the orange boxes on the figure. And those include things like differences in geography or race and ethnicity, because that could give us some clues as to what's going on with the increasing incidence. And of course, we need to consider all of this and how it's interacting with the patient's genetics. And those interactions could really affect different treatment options that might be given to a given patient. So obviously it's a complex problem, and that it will take a lot more research to solve these problems, but this kind of a graphic just gives you an idea of the framework of the different kinds of things that we think are really important for investigators to look at. Next slide, 11, please. So with that, I think I'll stop and take any questions you might have before I turn over the rest of the presentation to my colleague, Matt Young.
Great, Phil. That was fantastic. And thank you again for highlighting a lot of the work that's been done in the field. And without the support of many of our partners, wouldn't have been possible. But I do think that it represents, again, many organizations and international and national perspective. So Phil, we have a question right now. I know that you talked about the cohort effect. If you were going to talk a little bit about what that means, particularly from what we know around that age group, that specific cohort, and then what we might see in the future based on some of the trends for even very young, below that 50. Can you talk a little bit about what that cohort effect is and how that's helping provide insight about the future direction of research?
Sure. So just subdivide, when you're looking at large populations and these national health surveys, some of them have been tracking people and their health for over 30 years, over 50,000 people. So over the course of time, some of those folks have developed colon cancers and at different ages. So it's convenient for us to group cohorts, and in this case by age. So it might be by decade, those born in the 50s, 60s, 70s, 80s. And as you look at the data when it's broken down like that, you could see in that first graphic that I showed that incidence rates for the early onset cases were actually increasing. So it gives us a clue, or really that's the chief discovery, is these cases are actually increasing. And it was strange to see that based on the fact that we know overall rates in the country have been going down for some time. So we don't think human genetics have changed much over the last 40 years. So those cohort effects give us kind of guidance as to where we should be looking. What have these folks that are in the younger cohorts been exposed to that folks in the older cohort may not have been?
Great. And I think that's a really nice entree into punting to Matt. I know that we're a little behind schedule today, but we're going to go ahead and save some of the additional questions for after Dr. Young's presentation. But Phil, thank you so much for framing the issue and talking about all of the great research and what are the strategies that we're considering. Because I do think a number of survivors, advocates, and folks have really questioned, why are we seeing this sort of increase? I think, Phil, as you noted, human genetics in the last 50 years, 25 years haven't necessarily seen an evolution, but we really have to get to the bottom of it. So thank you so much. So Matt, I'm going to go ahead and turn it over to you, and we'll go to the second part, and we'll open it up for larger discussion at the end.
Thank you, Andy. Thank you, Phil, for your introductions. So I'm going to talk today about more about what's going on in the clinic. As Andy said, I'm working at the Division of Cancer Prevention, and we're looking at early diagnosis of cancers, which would also include early onset colorectal cancer. Next slide, please. So many of you probably know what's actually available in the clinic, or possibly more likely not available. So we can break down the clinical side of early onset colorectal cancer into prevention, screening, and intervention and treatments. Currently, we don't have any recommendations for cancer prevention or for cancer screening. For treatments, what we have is the clinical guidelines not consider early age colorectal cancer as a criteria to drive treatment. Basically, that what we're looking at as therapeutic options for early and late colorectal cancer are the same according to the major oncological societies. And the recommendations for more aggressive surgical or adjunctive approaches for early onset colorectal patients, at this time, it's thought lead to over treatment. So right now, there are no recommendations that differ from late onset colorectal cancer. For cancer prevention, it's very similar. What we know to prevent cancer will be the same for early onset colorectal cancer as for late onset. Eat a variety of fruits and vegetables. Don't drink alcohol or drink very little. Stop smoking. Exercise more often. Maintain a healthy weight. This hasn't changed for early onset. There may be new recommendations for prevention coming, but until we have further research, there's nothing outstanding that would be different than late onset. Similar in the screening mechanisms, there are no screening or early detection for early onset colorectal cancers. The symptoms are the same, and patients should be aware of the symptoms, and that's what's leading to patients seeing their doctor. Obviously, you know the symptoms: the painless bleeding, the persistent change in bowel habits, abdominal discomfort, weakness, fatigue, and others. So again, the same symptoms that adults, late onsets would have. So until we know more, there's nothing that's for early screening that's out there available. Next slide, please. Clearly, early cancer detection saves lives. Most cancers are diagnosed when they are large size. This means they most likely have already metastasized, which means treating it is much harder and more complicated. So to reduce cancer-specific mortality, we need effective biomarkers or other methods to assess risk assessments for early detections and for the therapeutic aspects of it. Next slide, please. So in cancer prevention, we have set up the Early Detection Research Network. This was established 20 years ago, and it's focused solely on developing biomarkers for early detection and risk prevention. It provides guidelines on validations and reference samples. It's unparalleled, fully operational, and open access. So all can join or view what's going on, and we have strong scientific collaborations. Next slide, please. So can we develop biomarkers for early detection for early onset colorectal cancer? Or can we use the biomarkers that are currently available for late onset colorectal cancer for early onset disease? Next slide, please. These are the current biomarkers that are available for late onset. Many of you should know these. The top four are stool-based. The top three are stool-based markers, and the fourth one is a blood-based marker. These are clinically available, FDA-approved tests that you can receive from your physicians for the early detection of late onset colorectal cancer. The sensitivity of these assays determines how well they detect colon cancer, and the specificity and shows how often that they will get it correct or not have a false negative. The top four are tests that a positive will lead to colonoscopy, where the colonoscopy is considered the gold standard, which most is the optimal assay to see. The NCI doesn't recommend or let me rephrase. The NCI does not endorse any of these methods over any of the other ones. This is a call for your physician that you should make on your own. Next slide, please. Next slide, please. So biomarkers for early detection require a high sensitivity and a high specificity. So the high sensitivity is what we call true positive. It's needed to reduce the false negatives. And the high specificity is we call a true negative and is used to reduce the false positives. The colon cancer, the colonoscopy is the gold standard and the standard of care used for screening in adults over 45. So you can go to your doctor and you can ask for a colonoscopy if you're over 45. Biomarkers that I showed in the previous slide, which were discovered and validated, were all verified by colonoscopy. For the false negatives that these markers may have will lead to a misdiagnosis, which is often detected within the next 2 or 3 years when the next time for the screening of those markers. The false positives will lead to unnecessary colonoscopy, which is the standard of care, so that's acceptable at this time. Next slide. Biomarkers, the test for early detection. These are the FDA requirements for a biomarker. The assay has to work analytically. It has to also work in the clinics very well. These are easy, as shown with the markers we already have. The fact that the benefits have to outweigh the risk is what is limiting our ability to put biomarkers for early onset colorectal cancer. The fact that we cannot overdiagnose people and induce them to unnecessary colonoscopy drives the risk of these markers, and show the specificity has to be much higher. Next slide, please. Other biomarkers that are currently being looked at by the industry, liquid biopsies offer the potential for multi-cancer biomarkers. Multi-cancer biomarkers, they're designed to detect multiple cancers. The idea with these is the sensitivity and the specificity are driven by one or two of the other cancers that they will detect, and allows us to approve them for multiple cancers, and allowing a lower level of sensitivity for some of the secondary cancers. Many of these are next-gen sequencing type assays. They all have colon cancer in them, and likely could possibly become markers for early detection. Next slide, please. We're also seeing companies move into detecting microbiome to predict colon cancer. There's this Persistent Medicine has an FDA device, FDA-approved device for a non-invasive collection swab that's used to collect the microbiome. They use artificial intelligence to analyze this data, and it's the beginning of understanding the microbiome and its role in driving colon cancer and possibly early onset cancer. Next slide, please. So lastly, I'd like to talk about funding opportunities that the NCI has, as Phil indicated early on. We currently have a provocative question now. Provocative question 1 seeks applications that investigate the etiology functions responsible for alarming increase in sporadic early onset cancers. As Phil said, this question has been driven by the interest in advocacies and others for the alarming rise in early colorectal cancer, as well as some other cancers. The RFAs or the funding opportunity numbers are listed here. Next slide, please. Other funding opportunities that are available include funding under the Cancer Health Disparities Group, which clearly early onset colorectal cancer falls in a health disparity area. Also, we have multiple fundings for microbiome specific funding. Again, these are not specific for early onset colon cancer, but they fall under the ability to look at these areas. Next slide, please. Finally, I'd like to present some of the what we can do now, or what can be done now. And so education of patients and medical staff is a start to how we can reduce the mortality for early onset colon cancer, educate the patient and medical staff to the risk factors and the early symptoms of colorectal cancer in our young adults. We need to educate them that this is a real problem. Understanding the risk, as Phil pointed out earlier, obesity, inactivity, consumption of red meat, inflammation, hereditary syndromes, and understanding the symptoms, the painless bleeding, the persistent change in valve. All of this needs to be made aware to our younger population, that not to ignore this or not to think that this will get better. I'm sure you've all seen the constant ads from Cologuard pushing their new product for cancer, for detection of cancer or colorectal cancer. This has driven the production or the use of this marker. Similar advertisement could make people aware of what's going on, and when they go into their doctor, they would not be afraid of asking. Again, this is my opinion and not necessarily the endorsement of the NCI. Last slide. So this will end my talk and open us back up for discussion, for questions.
Great. Thank you, Matt, for actually continuing to expand out the discussion about the clinical implications, types of screening modalities, as well as thinking about the biomarkers and different types of opportunities to understand the diagnoses and more about early onset disease. And I think, Matt, you opened by saying a few words about the differences of what we know and what we don't know about early onset disease. But reiterating that fact, I know there's been some discussion about whether a diagnosis of someone who's in their 20s as opposed to someone or group of folks who are in their 60s, is the cancer different biologically? And so I think going back to that slide of talking about those molecular difference, are we seeing different types of cancers between the young diagnoses and those who have a definitive diagnosis, as well as maybe people who are over the age of 50?
There are some data that says there's a difference in the types of cancer. It may be more, there may be more of one type in the younger adults, that it's there, it is present in the older adults, but the trend may be more to a certain mutation, a BRAF mutation versus a RAS mutation. So that's probably the main interest or difference. There, other differences are subtle, and I don't think there's really enough cases to drive a treatment or a early marker that would be different than what we use for late onset. Once we find differences, that could allow targeted therapy to be applied, but that would be more of a case-by-case study.
Right, exactly. But definitely an area of potential, which I think it's fantastic that you brought up the provocative research question. And huge kudos to the NCI for being responsive to the advocacy and scientific community and opening up early onset as a specific study. Let me just ask both of you right now, in terms of looking at this, because I think Matt and Phil, you both had referenced on some level, colorectal cancer isn't the only type of disease where we're seeing an uptick in the number of diagnoses in people younger than we would expect to see. Is there anything that we think that we can learn from the other cancer types or opportunities to study in parallel right now based on this trends that we're seeing in increased incidence in several cancer types?
So I'll jump in that, yeah, I do think there's an opportunity to understand where the difference or similarities may be. Some think that this may just be a shift in the age, that we're shifting down to both younger, for both all types of cancer into a younger age. That could easily be seen if we have similar markers or similar drivers, as we call them, in the different types of cancer. So clearly by studying the field, we may learn more quicker.
Okay, great.
Hi,
So
I'll just jump in with an additional comment. Matt's right. I think it's a great question about whether other types of cancer are increasing in early onset. And there are only a few that we know of. Certain subtypes of breast cancer and stomach cancer, along with colon cancer, seem to be trending younger. We don't know the reasons for this, but it would be valuable to do the kind of comparative analysis between those different cancer types to see if, as Matt suggested, there are some commonalities between them. But it's a question we simply don't know the answer to at this point.
Great. And I do think, again, that provocative research proposal is going to give some fantastic discussion and possible opportunities to research both the items that we've just asked questions about. So Phil, let me go back to you. And I think there are some questions, particularly as you showed the schematic. And again, that schematic specifically came out of a meeting in Denver with about 45 folks sitting in the room, thinking about what were the times of exposure, the types of factors that could be part of risks and exposures, different types of opportunities and the like. So Phil, we talked about some of the usual suspects, new players in the types of causation and things we think might be there. I think one of the folks in the audience had said, are we sure that that's the entire list? Are there other things that are out there? So I want to say that, you know, some of this, as pointed out, came out of meetings where we were looking at the priority factors and the like. But I think, Matt, you did a great job of talking about there are things we do know about, for instance, processed meat, some of the inactivity, obesity and the like that are known factors. But I guess, Phil, do you think that that's the exhaustive list of things that really could be contributing, or do we not know? How would you respond to that schematic that you showed? And then what else might be?
And one that was considered among the gathered experts, I'm sure it is not an exhaustive list. And there were some other ideas that were put out there. Everything, exposure to microplastics in the water, exposure, or this idea of you know, smaller nuclear families. So sometimes there's a immune benefit from having been raised in a large family. All of these things were considered. So I think it's absolutely true that there's no way even a room full of experts can cover everything that might be contributing to early onset disease. What we're hoping is, as the provocative questions and other funding opportunities are published, that the investigators who are sitting in their labs may have knowledge of some other exposure, or may be observing some local population with a spike in early onset cases, and investigate those connections. So I would think that there are other things that may be contributing that we simply are not aware of, and we would really like to know about those. So we're hoping that investigator-initiated proposals might start to investigate some of these unidentified risk factors.
Okay,
So
wonderful. So those at home,
I'd also like to point out that it's probably not just one component. It's probably a combination of multiple components. So it's not going to be a simple find out which one is the causative agent. So we have some ways to go for that point.
Good. So I've got some notes that we need to wrap this up in the next 5 minutes. So we are going to have to do this, and I know I'm getting questions rolling in left and right. So I do want to go back to the screening discussion. There are some thoughts and criticisms that some of the tests that are being used or could be used as frontline tests maybe aren't being used as readily because we might see a lot of false positives. And then I think building upon that, the question is, are there types of screening tests that we think could be used in the future to detect early age onset disease, or a type of physical exam that might be specific to the very young population? So I'll let you both unpack that question, and we'll probably entertain one more and call it good.
So I'll start with the screening, using the current ones to bringing it down to a younger population. And in fact, the American Cancer Society at a meeting with the FDA and the Academy, National Academy, has actually suggested that we look into this, lowering the age or testing these current markers in a younger population. This is probably the best, fastest way to begin because they're already FDA approved. The concern is if you have a positive test, you have to have an outcome or something, a response to that positive test, which would mean the colonoscopy. So we have to get to the point where the insurance companies are going to pay, or someone is going to cover the cost of a colonoscopy. So those tests are also for non-symptomatic patients. They won't work. They're not approved to use in people that come to the doctor's office and say, I have blood in my stool. So that would currently lead to a colonoscopy. So education of the doctors that a younger than 45 person with blood in his stool needs a colonoscopy, it should be the first key element to do.
Okay, great. Phil, anything to add?
No, I defer to Matt's expertise on screening and detection.
Wonderful. And to that, I'm going to have one more specific question. So Dr. Guru presented data at ASCO last year that I think was really validating what a lot of patients and folks have felt, that there is oftentimes mixed diagnosis, delay in diagnosis. And in Dr. Guru's study, he showed it was almost 290 days from the time someone presented with symptoms till the time they actually received a formal and accurate diagnosis of colorectal cancer. So I guess, Matt, you've done a nice job of laying out what patients should know about the signs and symptoms. Just a quick note or shout out about sometimes what are considered signs and symptoms that aren't connected to early age onset, or people who have misdiagnosis. Can you fellas share a little bit about also the provider community being responsive to these signs, symptoms, and patients presenting?
The provider communities, you mean healthcare, the doctors and the nurses and the clinics. That's correct. To me, a lot of the education needs to go because often they don't believe this is a problem at a younger age. And so by educating our healthcare system that not to ignore these symptoms and to be proactive. I'm not an MD, so I can't suggest or recommend what needs to be done, but maybe a group of MDs needs to get together and decide and set up a recommendations or for what to do when a patient comes in with pain in their stomach. With the current healthcare being mostly digitized now, it could be easily a red flag in the computer system that says you should follow this patient on a weekly basis, or you should recommend a colonoscopy, or you should send up to a gastroenterologist. These are the mechanisms that are being used for other symptoms of other diseases that need the primary physician to flag them, to move them to the next stage.
Wonderful. And I do know that many of our partners with the National Colorectal Roundtable, as well as clinical and public health partners, are working on this. And I think Dr. Dennis Anand, who's been a sage, I think, in the work we've done, and sent a really nice message thinking about early age onset disease in the study, that no matter what we find out from these trials, we've got to be ready to do something about that work, because we already know about family history. We know about many of the risk factors that were noted, but we're not doing an amazing job of educating or the patient or the provider, and we need to make more of an effort. So I think that is definitely coincides, Matt, with the messages that you've been putting forward as well. To wrap this panel up, I do want to just tell everyone, and I'm going to have one final question for Matt and Phil, but just remind folks that if you didn't get your question answered or have an additional question, please email it to advocate@fightcrc.org. That's advocate@fightcrc.org. And this is one of many conversations that we've convened or will continue to convene with the patient and the provider community. So we're excited to have both of these individuals who've put a lot of time and energy working alongside us. And I can't say how excited and how honored that I've been, as well as the organization, to really have you guys in step with the great work, as well as the Office of Advocacy. So I'm going to start with you, Phil, and this is our final question. This was one of the first questions I received, but it's, I think, a good way to round us out. We know research is being done. We know it takes time, but what can advocates do now to help research and or get the message out? So Phil, what would you say?
First of all, thank you for the kind words, and it's been a real pleasure working with Fight CRC to really help us develop some plans of action to go forward with this. Advocates do play a role in NIH activities. We have an office for advocacy, which can place advocates on things like review panels for grants, as well as at NCI sponsored and professional society sponsored meetings. And I think it's important for advocates to attend those meetings, voice your concerns. I'm always amazed at how well educated patients and survivors are. And you can tell us a lot about quality of life issues, survivorship issues, and I think just general medical care issues that otherwise wouldn't necessarily come to light in things like a clinical trial. They're looking at hard numbers and biological outcomes, molecular outcomes, but I think it's very important for patients and advocates to be able to tell us other experiences, because that also will give it more information on clinical annotations of the disease. Always helps us to figure out what else might be going on, and it's hard to know what's important and what's not, but to have the information, I think, is key, and the patients and advocates are the only ones that can provide that.
Wonderful. And Matt, the final word.
Oh, I get the final word. I agree with what Phil said, and I believe this organization has got the ball rolling and is really motivating a lot of people into looking at this. Clearly, this is a concerning issue that needs attention, and the sooner we put our attention to it, the quicker we can have some response and possibly a corrective effect.
Awesome. Well, thank you, gentlemen, so much for being on today and sharing. Again, I've had the great honor over the last year, and I just want to say that I feel like for anything throughout the course of my career that I've worked on, I've never seen a group of people be so responsive, nimble, I don't know that the advocacy community gets to see this on the daily basis, but I do. And to be able to see a working group that you guys have helped us and really people have rallied behind, because you are at the table. We're almost at 100 strong internationally. We'll either be in Spain with additional 20 countries there, talking about how to build off that schematic that we've all seen today and further that advancement in that research, or we'll be online doing that with maybe more than 20 or 30 countries on. But we couldn't have done that without the support and the leadership, and noting that NCI, DOD, ACS, CDC, and many of our great partners were behind us. And I think to go full circle, Molly talked today a lot about the legislative asks. She talked about the funding, the policy. We saw the amount that's being funded right now, but we also know that a lot of the money and support that's now moving this ahead, as well as the future, is going to rely on the advocate voice, I think, as both of you had talked about, to continue to ask for this dedicated funding, because this is a really global health issue, and we must address it. So the advocates on the Hill, everyone really thinking this through and making this clear to your legislators at home and at our nation's capital is key, because without those resources, we couldn't do this great work. So again, a huge thanks to all of our friends who've been engaged in all of our great work. And I'm going to send it off to our larger team to wrap us up for the day.
Great. Hey, everyone. Thank you so much for sticking with us and bearing with us through technical delays and all that. But a real thank you to Matt and Phil and Andi. There's so much great work happening, and we're so grateful that they could join us on a Sunday to talk about the things that they're working on and take our questions. So that wraps up our panel discussion for today, but Virtual Colon Congress 2020 is not over yet. And as we wrap up, I just want to take a moment to really thank you all for your patience and flexibility. A week ago, this was going to be an in-person event, and you all have really rolled with us and bared with us as we transitioned this to a virtual event and dealt with all the technology issues that come along with that. So thank you so much for continuing to support us and participating. I also want to give a huge shout out to the entire Fight CRC staff, in particular Aubrey and Nancy, who are here in DC with me, and the entire team who is online and has been helping us with questions. And again, it was a really big effort with a lot of blood, sweat, and tears to get this pulled off in a week, and we couldn't have done it without our amazing team, and we just feel really lucky to be able to work with everyone. I also want to shout out to our board for their support and encouragement throughout this whole process. Also our GAC, our Grassroots Advocacy Committee, and the Fight CRC ambassadors who jumped in from the beginning and helped to build an excitement on social media and get the word out about the change. We really couldn't do it, what we do, without you guys. And finally, last but certainly not least, I want to thank Brendan and our whole live stream team. If you could see here in the room, we've got this incredible setup, and I don't know how any of it works, but they've made it work, and so we're so grateful to them. You know, big virtual round of applause to them and the rest of the team. And so, you know, even though our speaker portion is over, that doesn't mean we're done for the day. Obviously, one of the best parts of Colon Congress is the time when we can get together and share our stories. It's always incredibly powerful and emotional, and just a really great way for everyone to connect with the rest of the Fight CRC family about what they're going through. So this afternoon, for the rest of the day, we would encourage you to share your story on social media. You can record a video of yourself. If I can do it here, you guys can do it into your phone. You could post a strong arm selfie, you know, whatever you feel comfortable with. But I think it would be a great way to help us connect with each other, even while we're practicing our social distancing. And so be sure to tag at Fight CRC, and again, use the hashtag CONC2020 so that we can see all of your amazing stories and, you know, get to know the folks that we haven't had a chance to get to know yet. And again, as a reminder, tomorrow we hit the hill virtually. And again, our goal is to send 5,000 emails to members of Congress in support of funding for colorectal cancer research and prevention. So again, this is a bold goal, but we feel, strongly that this is something that the colorectal cancer community can get behind and that we can reach, and we can really show just how strong and relentless we are. So keep an eye on your inboxes. You'll be getting emails tomorrow with more information about that. And again, thank you everyone for joining us today. So I'm going to send us off. We have a brief message from our president, Angie Davis, about her sharing her story and what Colon Congress and this community has meant to her. So again, thanks everyone.
This Colon Congress, this is a fight that has to continue, because for us to have a future without colorectal cancer, we have to put in the work now. Your members need to hear your story, and it is powerful. They're going to change their vote because of your story. They're going to change their vote and support because of you. Our members of Congress are put into office by us, and we are exercising our right to tell them what is important to us. If we don't do that, if we don't tell them what we value, they're not going to change their vote. They're going to go with who is loud enough to say this is dang important. My life rests on this. I need you to invest in research because I'm waiting for a cure. And you should be comfortable telling that to them. They work for you. So that's what I really want to tell you. Every single person in this room, if you've been here 10 times, if you've been here for your very first time, they work for you. They owe you the time to listen to you.